Good morning, everyone. Welcome to the AIIMS Silver Jubilee Oration. For this session, I would like to invite to the dais Honorable Director, Sir, Dr. M. Srinivas, Dean Academics, AIIMS, Dr. Kaushal Kumar Verma, and our esteemed guest and speaker for the session, Dr. Yogesh Jain. I request Director, Sir, and Dean Academics to please welcome our guest speaker, Dr. Yogesh Jain, with a bouquet. I now request Dean Academics, Sir Dr. Kaushal Kumar Verma, to please introduce the Silver Jubilee Oration and our orator for today.
Thank you. Good morning, ladies and gentlemen. It's my profound honor and privilege to welcome you all to this Institute Silver Jubilee Oration. Institute awards Silver Jubilee Oration to an eminent scientist from India or abroad for his or her outstanding contribution to science and also to society. The contribution of the individual in the last 10 years are considered for the award, and the past orators have been extremely famous, very eminent people like Dr. Chopra, Dr. Pentel, Dr. M.G. Dev, Dr. Mudgal, Professor Salim Yusuf, Dr. Dhaban. And last year we had Dr. Rajesh Gokhale, the Secretary and DG of the Department of Biotechnology, Government of India. And this year we have an equally eminent and committed person from our own fraternity, our own alumni, Dr. Yogesh Jain, who would be delivering this Silver Jubilee Oration. So, ladies and gentlemen, please join me to welcome Dr. Yogesh Jain to the auditorium. Give him a big hand, who will be speaking on medical academia and people's health. And let me just say a few words about Yogesh also. He is a renowned physician, educator, public health advocate whose pioneering contributions have brought healthcare closer to the underprivileged people and the underserved people of the community in the India. Yogesh received his graduation from here. He joined in 1982, did his post-graduation in pediatrics, and subsequently joined faculty and was here with us till 2000. Then he decided to move on to do some better work, some social contribution, and he co-founded the Jan Swasth Sahyog, which was placed at Ganyari, Chhattisgarh, and also co-founded the People's Council for Equality and Health at Sangwari. He still continues to nurture these organizations. His contribution to public health have been transformative and enormous, from designing first health and wellness center prototype, now a national policy, to pioneering the concept of community health officers, which wasn't there. He has redefined primary health care delivery in India. His initiative at Pulwari has given thousands of underprivileged children a healthier start of life. Beyond innovation, Yogesh has been instrumental in shaping policies and bringing healthcare closer to those people who needed it most, the tribal community, the underprivileged people, and he played a clear role in launching the ASHA program there. His contribution to national health policies and committees which strengthen the backbone of community health in our country. He is an educator. He has trained and mentored numerous medical professionals, ensuring quality healthcare reaches even to the most remote corners of the country and most people who are denied or who did not have the privilege of these facilities. He is an adjunct faculty to some universities. He has been a lead commissioner for the Lancet Commission on NCDs among the poorest Willian population. His unwavering dedication to health equity and his relentless pursuit of solution to marginalize make him a beacon of hope for all those people who actually need it and for us also. Today, we are not just welcoming an esteemed expert, he is a change maker in the country and a role model for several of us and our, say, the young student who has true spirit of compassionate and say dedication to the people. So, ladies and gentlemen, once again, I extend a very warm welcome to Dr. Yogesh Jain. And on a personal note, he is a very quiet, very humble, very gentle, unassuming person whom you can, not imagine as to what he is doing in the field and for the community. Welcome, Yogesh, and it's our honor and privilege to have you here for this oration. Thank you.
So it's a privilege for me to be able to speak at my alma mater. 43 years after I entered the ramparts of this place, and this is a place that I cut my teeth. I learned the technical descriptions of God in medicine. Uh, Also learned critical thinking, if I may call that, as well as learned how to learn. Besides learning sociology, anthropology, and politics of health, that allowed me to sort of make some moves in my life that I did. And so I have been a student, a doctor, and then a doctor teacher at this institute for some time, and then decided to relocate to rural central India because when the equity bug bit me, primarily to provide service to the people who needed it more, who needed it as much, if not more, than the people that one was serving in Delhi. And also then in the process, understanding the whys and hows of illnesses, but also understanding public health through N of one, and from single even patients, a single patient also teaching us public health. At the same time, trying to find solutions to common health problems, health concerns that don't have a solution at that particular time. So in this way, my journey has allowed me to sort of contribute along with the team that I've been working with to the idea of a community health worker, the ASHA, as we call her, for serving the 1,000 population, the mid-level health worker, between the doctor and the ASHA, which is called a community health officer now, posted at the third infrastructural locus called the Health and Wellness Center. In fact, the first Health and Wellness Center was one that we sort of set up in Chhattisgarh. Also getting actually, for an illness that is due to deprivation, food for tuberculosis patients, even though it has been provided in a very miniature way now than what we had proposed, but providing food for all tuberculosis patients in this country, as well as even running, full day crashes for rural children, as much as, crashes as an idea that was for urban areas, was something that we started for the under 3 child to solve the problem of, of insoluble problem of under 3 child nutrition. So this journey, this particular ways took me to, from Delhi to Chhattisgarh, where we chose to set up base in this part, in central part of Chhattisgarh and now in northern Chhattisgarh, where access to healthcare as well as hunger, as some people like to call it, malnutrition, is a determining forces that determine people's health or the lack of it. So like in Bilaspur in central in Chhattisgarh, we could serve a population of about 3,000 villages who access the health center, and a 3-tiered program that allowed outreach clinics plus 72 villages where we could run an intensive village health worker program that led to the ASHA program later. And in Sarguja in northern Chhattisgarh, serving about 550 villages in an agroforestry economy and running clinics in some of the most deprived areas, but also now working with the public health system to support that. So running busy outpatients clinics, as well as providing generic drugs, high quality generics to people, also to run laboratories from the small things like a microscope, a colorimeter, and a centrifuge, to even doing cultures of mycobacteria, in this case the rough, tough, and the buff that you can see, or even developing appropriate technology for rural people to be able to practice, you harness the science principles, science technologies that have come out, or to despecialize in healthcare, learning across specialities, to despecialize and to even use, technologies like this teaching stethoscope that has a single chest piece and two earpieces, one for the trainee and one for the trainer. And I would say here, pause to say that, how has action outside the institution that I grew up in has helped me. First, it allowed me a pragmatic solidarity with the marginalized. There is a huge unmet need for healthcare, and that is something that we could provide. But the other important learning that I felt was that praxis, the fact that you work and not just theorize, has been the best teacher for learning about research, about social and political aspects of health, as well as it is a litmus test for suggested policy and practice changes that we have been used to. And also, finally, working, thinking, and contributing to the improved health of the rural people in central India, at least. And this journey for me has been from individual to public health, where the yardsticks and ethics and goals are actually similar, even though and it's a continuum where the tools may be different, the scales are different, but this is what we could do. So this journey was from individual to community health, from curative to adding preventive work, from service to adding training and advocacy, and healthcare to structural determinants. So I recall here, this German scientist, doctor, in fact, Rudolf Virchow, who said, that if deprivation is a cause of illnesses, then doctors become the natural attorneys of the poor. And in fact, he said it very presciently. Medicine is a social science. It's not a biological science. And politics is nothing but medicine at a large scale. He was a cell pathologist. He gave us a cell theory. And then he, investigated the epidemic of typhus fever in Upper Silesia in Prussia then, and later became a parliamentarian who argued with Bismarck to trying to get health for the people. And he, in fact, coined the word social medicine, which allowed me to sort of, theorize this matrix of a good doctor for people's health. So my type 1 doctor, if I'll have type 1, type 2, and type 3 doctors that I propose here. The type 1 doctor is one who actually sees a single patient who comes with the symptoms, looks at these symptoms, does the right the examination, then advises the appropriate investigations, and then when all the information comes in, makes a diagnosis, then heals the body or the mind as the case may be, or operate, and then also counsel and teach. If there are medical students around, teach them to become better doctors. A typical medical college clinical faculty would be one such. It will be my type 1 doctor. My type 2 doctor will be who will not only look at this empirical thing, not only try to diagnose, but also then address the whys and hows of ill health. Say if there are children coming from with gastroenteritis from a particular locality, even looking at whether the water quality is okay or not, or whether hand washing practices are there or not, or if there is malnutrition in a particular area, is it because the PDS is not working? Is it because people don't have adequate food? And then look at those issues. Would be my type 2 good doctor. And that good doctor would be usually in, say, some public health schools in our medical establishment. And my type 3 doctor would be the one who looks at more fundamental determinants of ill health. And those issues may be political, if at all, or social. For example, why if people are not able to access drugs in this country for their illnesses that kill them, working on pricing of drug policy, pricing of drugs is a work that our doctor should be doing also. And that would be my type 3 doctor. And you could switch between type 1 and type 2 to type 3 at various points of time. It's not that you're carved into one space. So if someone asked me what type of a doctor am I would call myself a doctor between 2.5 or something, aspiring to be 3 sometimes, but when required also being type 1. And this is what, we all, I just propose this. And thus, with this background, I thought one could interrogate, the medical academia from where I came, looking at what have been the major contributions of the medical academia to people's health. And some places where we have not done well is something that I would follow with this discussion. So my first, acknowledgement of the big role that the medical academia has played in people's health is that it has been the first port of call for difficult medicine, say extremely preterm care or severe obstetric emergencies, or for critical care, for cancer care of all types, for subspecialty care, whether it's cardiac, neurosurgery, or other, all the subspecialties that dot our medical establishments, genetics, and nuclear medicine, investigation, intervention, radiology, and microbiology. These are areas where the medical academia has held held fort, and I would define this word called appropriate tertiary care. Primary healthcare can be healthcare that is provided at various levels, whether it's primary level care, secondary level care, and tertiary care. And appropriate tertiary care is as much a need of the poor as of the rich, probably more. So, and by retaining the service provision of this tertiary care in public systems, we are able to speak loud and clearly its importance. I think this has been a seminal contribution from the medical academia in our institutions. And the policymakers, if I may comment on this, they are out to hand over the tertiary and secondary care to the private sector. This is happening not only in India, but elsewhere. And by holding fort, I think this is we are preventing it from happening, and that's why a big thank you. And for those medical college faculty who continue to work in public health systems and not succumb to the love of extra money that the corporate health system provides, a big shout out. So I would say, why more privatization is not a way to go for this country, because all attempts to privatize public systems have failed. At least I can speak for Central India, whether I'm paneling private laboratories to run health systems, services, or to run these mobile medical units. And also people are forced to make a choice to go to private setups when public systems don't function well. So, but if the public system is sick, it needs to be worked upon to improve it, not to throw the baby along with the bathwater and give it to the private sector. So, so nowhere in the world, if I may say, or any state of India, has a private system provided equitable care to all. This is the fact that I think we'll all have to accept. And allowing public physicians to do private practice has been a disastrous policy, which some states in this country are allowing, since the conflict of interest cannot encourage people to serve well in the public system. My second acknowledgement of the work that the medical academia has done has to provide a learning ecosystem. Our medical colleges that we not only train doctors in knowledge and skills, we create teachers, we have created researchers and health practitioners in various situations, but these are also cauldrons for, learning critical thinking. They should be, at least, if they are not. And encouraging doctors to speak up, to discuss, to debate, and to dissent also. Why not? These are places. This is where medical institutions like this, which are housed in tertiary setups, at least, should be the places to provide. There are certainly challenges that are challenges to this entire function of the medical colleges. For example, people going west and or internal migration to the private sector has been challenges that the medical faculty will have to sort of deal with. And my third reason for acknowledging the medical college faculties are to generate evidence that can be used for policy implementation. I think this has been also a major contribution. For example, portal hypertension is due to an extrahepatic obstruction due to a portal vein thrombosis or due to an NCPF. And the surgical procedure for that was done by Professor Nandi, who's also sitting here, as well as his team. That iodine deficiency is also a cause of hypothyroidism, and that we need to ensure adequate iodine intake, and that led to the universal salt immunization iodization program in the country was due to work that was done by the medical college faculty. The Sri Chitra valve that was developed in Trivandrum, or polio immunization has to be delivered in a pulsatile way to eliminate the disease. The pulse polio program came from the work that was done at CMC Vellore and other institutions. The rotavirus vaccine for preventing childhood diarrheal deaths also came up from this institution and associated institutions. Paul Brand's work in managing leprosy holistically came from a South Indian institution, which has guided how leprosy has to be looked after. Snake bites care, and there is a various types of benchtop clinical and field-based research and even translational research that is being done. I think these are major contributions that the medical academia should be acknowledged for before we start sort of, asking questions, where can we do better? And my first sort of, my unhappiness, if I may call that, has been that, we have allowed public health systems and medical education systems, at least in this country, to run parallelly without speaking to each other. So, even though we are part of the same department of ministry, these are two parallel non-communicating systems. The more qualified and competent physicians are not contributing to public health care. There is no prestige in serving in the public health system in a district hospital or a CHC or a PHC. But if people they don't get a placement in a medical college, then they would rather choose to, move away. And even at a governance level, there is a different directorate for, for a public health care and for medical education. For skills level, and even at praxis level, there is a divorce between these two departments, medical education and public health systems. And thus, medical colleges tend to be islands among a sea of dysfunctional health systems that are marred by incompetence, power games, and I would say corruption. So I have some suggestions for mitigation to this. Can't faculty members have dual positions in national health programs? Why can't an assistant professor of medicine be also the district tuberculosis officer? Part of the time. And similarly, someone who's running the why can't a nursing college faculty be also serving the district hospital how to run systems there? But medical colleges should also nourish and flourish and support a few referral centers. For example, why can't each medical college take about 2 or 3 district hospitals and support them how to, even teach surgical techniques, to run a radiology service, to run a laboratory. These would be, and this is something that we tried in Chhattisgarh. Also giving associate faculty status to public health system practitioners, which is done in many Western medical institutions. Harvard is doing it. CMC Vellore in India has been doing it. I'm sure there are many places in the Western world where dual positions are also given, adjunct faculty position to people who are practicing in public health systems. Why can't it also happen here? This idea of a professor of practice was being talked about. Why can't we have people who are practicing be also given a, the additional label of a prof before their names or something? Why not, if they can, help in improving care? And why can't we even allow our faculty members to work outside the 4 walls of medical institutions? This is something that beats me when we are not consulting this. My second reason for worry about medical colleges faculty is that, going from evidence that we generate to policy making is something that we have not done so well. Why? Because the world of policy making is a messy world. There are many players in the process, and medical evidence is only one of them. The process, involves deliberations. It involves listening to others, which some of us are not used to, listen to. Negotiation and lobbying is also needed when you are actually making policies. And this is often committed beyond the remit of medical academia. Ye hamare bas ki baat nahi. And, but there are examples like this. The much touted universal healthcare system in Thailand came from a collection of 7 doctors. 4 of them are faculty members in Thailand, and 3 were in the public system, and they came together to develop the best health system, which even NHS of UK is jealous of, if I may say, the Thai universal health system. Or getting, universal salt iodization in this country also happened because one lobbied for the policy change also. And defining brain death, which allowed cadaveric transplants to happened also, sir, because of, your sort of championing this policy making thing. So this is I think can we go for that also? And my third reason is about research, which is also the topic for these 2 days that we are having the research day for. Certain topics have not found their way to be researched. For example, violence, whether it is custodial violence, whether it is gender-based violence, and whether other types of violence are not something that are, sexy ideas for research that we have said. We have also talked about epidemiological research. Efficacy-based research, if you look at it, usually ends with a short paragraph in the end on policy implications, which no one reads after that, after writing it. And now there's a new kid on the block is implementation research. how to do things, how to implement what works. So certainly that is a way to go, but I would add additional bit, getting into action-based research, which is real-world involvement, and action actually enhances the quality of research as opposed to detached research. One worries about conflict of interest and mixing things, but I think action-based research and not detached research is only requires intellectual honesty, which I think we have in sufficient amount, simplicity, and it involves learning from experience and openness to debate. But let's just step back and look at what was the role of the medical academia during the COVID pandemic management. In a situation where there was little evidence to support policy making, the medical academia, let's face it, could have done a little better job than we did. We backed some therapies that did not stand scrutiny. We made predictions about the course of the pandemic that were way off the target. And certain medical social policies, such as the complete emergency lockdown, were not even questioned by many of us. My largest grouse about medical academia has been that we were expected to play a role of a watchdog for bad health policies and speak up, which we did not, which we haven't done in good measure, is what I would say. I would give an example in which I was involved personally about tuberculosis drug regimens. In 1997, on the advice of the WHO, Government of India launched the directly observed treatment short course therapy, which involved thrice a week 4-drug therapy for 2 months and then 2 drugs for 4 months, given intermittently. We also started using it when I moved away from here. But in 2005, we realized that the intermittent treatment that we were giving was resulting in excessive relapses. People were, after getting cured, were coming back with the disease. So we stopped using it and we shifted to daily frequency. When we argued with the WHO, who was the daddy which allowed all the countries to sort of use the regimes in 127 countries, we lobbied with them, and it took us 6 years to change their regimes to daily treatment. 6 years, from 2005 to 2011. And subsequently, in the next 5 years, 122 out of 127 countries decided to go to daily treatment, but not India. Our own tuberculosis academia questioned us. We were called, people who were seeing 500 odd patients in a year, and we lobbied along with the WHO to the Government of India without success. And in 2017, there is a district tuberculosis officer of Faridabad district who was also troubled with treatment outcomes like what we were. And he went to the Supreme Court and he argued the case on his own. And we prepared the affidavits for him. And the Supreme Court passed an order to change the drug regimens in the next 2 months. Why did the medical academia not listen to earlier and suffer the ignominy to be advised by the judiciary about a medical technical issue that you should change drugs? A judicial officer should be telling the medical academia that the drug should be changed. So there have been other bad policies and I would say worse position that we have had. Leprosy was supposed to be eliminated by a frequency of less than 1 in 10,000 in 2005, but we didn't question it. People used to grumble in private circles, but no one questioned it. Tuberculosis elimination is being asked that it will be by the end of this year it will be eliminated. I think no one in his or her senses would agree to such a thing, but I don't hear I don't even hear a murmur. Forget about a rumble about questioning that this policy that is happening. Malaria is supposed to be eliminated by 2030 and is coming back. I can tell you for Central India in 2023 and 24, we are having at least 3 times the number of cases than what was happening during 22 and earlier. Sickle cell elimination, a genetic disease being eliminated by 2047 is, I think, is a laughable idea. How can you eliminate a genetic disease like an infectious disease? And we are focusing on screening without treatment. This is something that I can't understand. It has not worked anywhere in the world. We are the only country which is thinking of eliminating a genetic disease also. And even saying no to the privatization of public facilities is something that I would say, if we are proud of our public systems, why are we not even questioning it? So my pose the question, why does the medical academia not speak up? Do we think that it's not part of our remit? Or, is it that the medical college faculty look for refuge away from the messiness of public policy? Or worse, a stick from the political establishment? medical college, I must say, is extremely, truly physically overwhelming. It is bone marrow tiring, the work that you do. But I've seen among so many of my colleagues, ex-colleagues have been doing this. So, health activists, as I might be even labeled as, besides being a professional, we have to be, someone has to be speaking up for some concerns. And there are very sparse networks. If the academia does not support some even of those people, then there is a problem. I know professionals have a dislike for organized effort. It is called union baji or whatever else the words may be used. In fact, my worry is that as opposed to our activism efforts, would it be unfair to label medical academia as pacifists or as status quoists? There are formations in activism in health, like the People's Health Movement, where people are hungry for, technically correct in material and efforts from, to help them in their efforts for advocacy, where it's not. So would the academia get out of their comfort zones to engage, or are we inherently risk averse, is what a question that I would leave with. I'm not even talking about my type 3 doctor. Did the medical college faculty engage or oppose the forced sterilization that happened in 1975? What was the role that the Bhopal Medical College play after the MIC gas in 1984? What has the US Medical Academia done after when their country was, what their country has done in Gaza? Forget about that. What have they talked about, their imminent ban on all abortion that is going to happen in US? Is the academia speaking, or is it supposed to speak? And what has been our own response to the health crisis in Manipur? So, and I would end by saying, one of my basic dilemmas about medical academia and people's health, the people's health in unequal societies is a socialist project. Let's face it. Even the foremost capitalist countries of the Western Europe and UK have a health system which is very socialist. They cannot get away from health systems cannot be a capitalist idea. And the problem is that the gaze of the medical college faculty is actually on the individual, rightly so. But can it be also, can it be the gaze be extended to the community is what I'm asking, which is also the strength, it can be the strength. And I'm not saying only ask the public health departments to be doing it. I'm talking about, even clinical faculty to be doing this. Now, what I'm trying to explore here is whether this gaze can be expanded here. I would end by asking this thing, you have to decide whether small is beautiful or you want to go big for impact. And I would just use, Harry Potter once to say that it is the choices that show what we truly are, far more than our abilities. Thank you for your attention.
Thank you, sir, for sharing your challenging journey and the valuable insights and vision that has emerged from those experiences. I now request Dr. Srinivas and Dr. Verma to kindly felicitate our esteemed speaker with the Institute plaque and a certificate. Sir, we would like to honor the guest with a shawl as well. Thank you, sir.